Cool. I hope everyone can hear me. It looks like I'm on mute, but I'm actually sat next to Lorna. So welcome to our today's session. For people that don't know, I'm Nat and I've got Lorna here, obviously, who we're the clinical educators. We've put together a sort of a bit of a whistle-stop session today, really, on neuromuscular diseases. We wanted to focus the session really around the respiratory management of these patients. And actually, we're going to mainly focus the session around the use of Clearway with neuromuscular disease patients, as I think this is sort of this is what we found as we were looking more and more into this, is this sort of naturally became the focus. So it's obviously only an hour session, and we really can't include everything about this patient group in this session, so it's by no means exhaustive. So we are just going to have a very, very brief overview of some more common neuromuscular diseases that we might come across, the respiratory problems that are associated with these neuromuscular diseases, and like I say, the respiratory management of these neuromuscular disease patients. We're going to relate it to some case studies, and like I say, the focus will be really around the management of the Clearway, and we're going to refer to the Clearway throughout this as MIE, just to keep it consistent, because that's sort of how that's the way it's used in a lot of the studies and the research that we're going to refer to. And actually, Lorna will relate some of the stuff that we're going to say to some evidence for MIE in relation to neuromuscular disease patients. Very, very quickly then, what is a neuromuscular patient, or what is a neuromuscular disease? So again, I am by no means an expert on this, and there's plenty of neuro people on the call who will be much better equipped to talk about neuromuscular diseases. Essentially, it's condition that affects the muscular function due to neurological impairment of the muscles, nerves, or neuromuscular junction. Again, we're not going to go into the sort of very detailed physiology around this, as that's a completely different session. Again, very small list really of probably the more common neuromuscular diseases that we come across, probably on both sides of the city. So MS, MND, muscular dystrophy, myasthenia gravis. Again, not an exhaustive list, but they're probably the common ones. And then we sort of have added in Guillain-Barré syndrome onto this, as actually we're aware that it's not classified as a neuromuscular disease as such, as it is an autoimmune disease. However, we do very much feel that it sort of fits into this patient group in terms of the problems that these patients have and the respiratory management of them. I think the next slide is just going to touch upon motor neurone disease, which is going to relate to the first case study that we're going to talk about today. Again, not an expert, but just in terms of a brief summary, motor neuron disease is characterised by the progressive weakness or wasting of limbs, bulbar and respiratory muscles due to the selective degeneration of both upper and lower motor neurons. And I think one of the most common types that probably we all will come across most commonly is the ALS type of motor neuron disease, which often is referred to in America as MND. There's a few other different types that some different types, progressive muscular atrophy, that just affects lower motor neurons. ALS affects both upper and lower motor neurons, and it often affects speech and swallowing as well, so a lot of the bulbar muscles. There's other different types that are a lot less common, so something progressive bulbar palsy that is often to do with obviously bulbar symptoms directly affecting the medulla oblongata. But today I think the case that we're going to talk about is of an ALS patient, as this is probably the most common. And then the second case study we're going to talk about is, like I say, not your classic neuromuscular disease, but certainly I think probably we would all group into this sort of category of patients, of a GBS patient. So as we've said, it's an autoimmune disorder where the body mistakenly attacks its own healthy cells, damaging the myelin sheath that surrounds the axon, and as a result, nerves can't transmit signals efficiently, causing weakness and reduced sensation. Often it sort of follows a period of sort of a viral or a bacterial infection, possibly days or weeks afterwards. it often comes on very, very quickly. Symptoms can worsen and progress over the course of hours or days, and the symptoms are normally bilateral. You can get away without having respiratory complications with GBS, but often it is associated with respiratory muscle weakness, and when that does happen, often ventilation is required and admission to ICU. We're just going to move on now to our first Mentimeter. So if you can all just bear with us, can you just see at the top of the screen now, there's a little website, so www.menti.com. If you can all just go onto your phones, bob that into Google, it'll come up and it'll just ask you for a code, and if you put that code in at the top, we'd just like to spend 2 minutes of getting a bit of information from you guys about what you think are the common respiratory problems associated with neuromuscular conditions. So it can be the ones we've talked about, or any other neuromuscular diseases that you've come across. Thinking about what generally are the common problems that you come across with these patients. So it's a bit of a word dump. It's all anonymous, so you don't have to put your name into Mentimeter. You can just put a letter or your team name, and then hopefully we'll just get a bit of a word dump on the page here, and we can talk about it.
You might
just
even
give you a couple of minutes.
Be able to be an emoji on me.
Oh, you might be able to be an emoji. There you go. If everyone's happy with that, we'll just give you a couple of minutes. If you've got any problems, just put it in the chat or put your hand up or just speak. Oh, there we go. Thanks, guys, for being the guinea pigs. Yeah, so we're getting poor lung volumes, chest infections, poor cough, secretion retention, inability to cough. Yeah, again, something about tidal volumes, collapse, poor respiratory effort, unsafe swallow. Yeah, give you just another 30 seconds. Everybody's done that perfectly.
It's really pretty.
It does.
Collapse.
Yeah, I think you've sort of nailed it on the head really there. I think all the stuff that we've got written down, so again, poor swallow or potentially unsafe swallow, that's going to put these patients at really high risk of aspirating and developing a chest infection, so an aspiration pneumonia, which often we're needing salt input for, aren't we? One thing, difficulty with communication as well, sort of comes hand in hand with those bulbar symptoms, so not only swallowing but also speech and communication. What else did we say? Unsafe swallow, yeah. So again, sort of on that line, thinking about how these patients are managing their oral saliva and their oral secretions. And actually, Lauren's got a fun fact for you in a bit about how much saliva we produce normally. So actually, if those patients have got poor swallow or an unsafe swallow, actually what's happening with their oral secretions, and actually how are they managing them or how are they not managing them. Weak cough, secretion retention, yeah, everything's sort of encompassed there really, isn't it? So this leads us on really nicely to probably the main focus of today, which is going to be around the secretion clearance element of sort of the respiratory management of these patients. So I'm just going to pass you over to Lorna, who is just going to talk you through some secretion clearance stuff.
I seem to have lost my camera. Don't know what I've done with that, but never mind. You don't need to see me. You can see my screen. You haven't got me up. No, I've lost it on my screen, but the slides are more important. So obviously, those problems that we've identified, secretion clearance and cough, were kind of some of those big problems. While we were preparing for this talk, both of us have gone away and sort of done quite a bit of research into secretion clearance and respiratory management of neuromuscular diseases, gone down various rabbit holes and come across lots of evidence that, sort of more up-to-date stuff than I've probably had time to look at over recent years. And we'll be summarising some of that as we go along. Some of the key things to think about is that when we're thinking about secretion clearance, usually in a neuromuscular disorder or a neuro patient with like a GBS patient, the reason for having difficulty clearing secretions is really because the respiratory muscles are weak, not that there's an issue with mucociliary clearance. So some of the other patients that we would treat in respiratory might have impaired mucociliary clearance, unless there's another problem. So if somebody has COPD, then or bronchiectasis or something else where there's going to be an issue with mucociliary clearance. Primarily our problem is around respiratory muscle weakness, and that relates to cough. We're going to talk quite a lot through this talk about peak cough flow values, and this is quite an important part of our assessment, which we do more in sort of longer term management of neuromuscular disorders. You might do it in some specialist areas, and often in acute areas we probably don't think about it too much. It's not always appropriate or possible to do it in acute areas, but we can. It's worth us bearing in mind and thinking, what would we guess it would be, or what would we expect if we were to assess it? And we know from research that peak cough flow values above 160 to 200 litres a minute are needed for an effective cough. So when you've got a patient who has a peak cough PCF below 160, they're not likely to have an effective cough. So their secretion clearance is going to be impaired. This next slide is a really nice diagram from this article from Walsh in 2011, so a bit older now, but really lovely diagram to show what happens with sputum movement with airflow and how we relate this to what we do when we're using different interventions to clear secretions. So we can all think of this in relation to what we do with active cycle of breathing, but A shows there that the expiratory flow is what pushes the mucus forwards, and I think we always think about that in terms of a cough, but the other thing to bear in mind is there's slight airway compression that helps sort of push that along, and that's just through normal expiration. In inspiration, the airways dilate and that sort of spreads the mucus out. When we then try to clear secretions through a cough and whatever else we use to augment that, this kind of pinch point of where the you get that airway compression can push that mucus along, and it creates this turbulent flow that shifts the phlegm. So it's quite a nice diagram to sort of visualize what might be happening and think about how it relates to what we do in the interventions that we use. Thinking about how we assess cough and cough strength, we obviously use lots of visual things, and we can assess it quite subjectively by looking at the patient. Do we see that they get a good enough breath in? Do we what do we see in terms of their expiratory force when they cough? How does it sound? We can tell if someone's got a poor cough, can't we? But we've got some more objective measures in the form of an FVC, so what's used in spirometry, or a peak cough flow meter. So on the right of your screen there is the peak cough flow meter, or PCF, because it's easier to say. This is the peak expiratory flow measured during a cough. So in basic terms, it's how quickly you can blow that air out of your lungs when you do a cough. The normal range is 360 to 840 litres per minute, so quite a big range, but that sort of lower number of 360, we've said on the previous slide, kind of above, you need it to be at least above 200 to have an effective cough. So there's evidence that a peak cough flow below 160 won't necessarily sort of shift the secretions that you need to. So we stick a mask on the end of that peak cough flow, that flow meter, to assess the flow while somebody does a huff or a cough. FVC, our forced vital capacity, is the amount of air that can be forcibly exhaled after taking a large breath in. This is comparable to peak cough flow. There's going to be a direct correlation that if you can't take a deep breath in, you don't get that expiratory force. So we're measuring different things and we'll get different values, but we're measuring volume as opposed to flow with this one. But we would see, if we've got a reduced FVC, we're likely to see a reduced peak cough flow. So those are useful tools when we're evaluating the patient who's perhaps more stable, and where we might want to measure that as we go through. In terms of choosing interventions, we're obviously focusing on MIE today, or cough assist, but came across this this sort of visual here on a really useful webinar that talks about a paper from Michelle Chatwin, and it's actually Michelle Chatwin presenting this webinar that I've got in the references, and if you want to look into more of this, the BRIAS webinars are really useful and give some really good information. This was used, a group of experts had a meeting in 2017 and wrote that up in 2018 and created this, which shows you the lower sort of FVC or peak cough flow. It puts you in that sort of red zone, and this is where you need assisted cough with the intervention. If somebody's if they're in that yellow zone, then you might need to assist their cough in some form, but that might not need to be a cough assist device. It could be treatments with using bag and mask to breath stacking, those sorts of things. And if they're in the green area, then they don't need any assisted cough. So what we're looking at today is patients who are in that red zone. And even if you don't necessarily measure those things, it might be worth you sort of thinking about this and thinking, is my patient in that red zone, and how does that guide the intervention that I use? It also looks at the cost of those things. So obviously the more independent measures the patient can participate in, a lower cost, and the triangle at the right hand side is about the amount of assistance provided. So the more passive interventions, where there is much more assistance provided, like a mechanical insufflation exsufflation, MIE, that's a much more passive intervention. So yeah, in terms of the wide range of choices that we have of treatments, it's quite a nice visual to think about what you might include there. So moving on now to a case study. This is made up, really, based off bits of experiences from different patients that we've seen over the past few years, perhaps, or over previous years. So it's a patient with MND, diagnosed 6 months ago. It's the ALS type. They've been admitted to ED with increased drowsiness and difficulty in breathing. They live with a partner, they've got downstairs living, and they're walking with a Zimmer frame. They have a PEG feed, which supplements a modified diet. So they are eating, but not sort of fulfilling all their dietary requirements with that. This next slide just shows you some of the information from the assessment, and we'll have a think about what the problems are. So we're going to move on to another Mentimeter slide to just share a few ideas in a moment. So in terms of neurologically, they are scoring 10 out of 15 with their GCS. They're opening eyes to pain, I think that is, verbalizing sort of incomprehensible words, and some sort of flexion movements. They've got a heart rate of 68, their blood pressure's 119/78, the temperature's 36.8, so things looking fairly stable there. They're currently on a 40% Venturi mask, self-ventilating, SATs are 90, with a respiratory rate of 26, but you notice they've got shallow breaths. This is the blood gas on 35% when they're admitted. And on auscultation, it's quiet throughout, but especially in the bases. The X-ray is generally a bit hazy looking, but some probable collapse or mixture of collapse consolidation on the right mid zone. So next of all, I just want to think about what problems this patient has. So just bear with me a moment while I share Mentimeter, you can read the gases and have a think. So on your phones from the last slide, you might just need to press refresh or possibly put the code in again. Hopefully you can see this and you can add some comments. If you're not seeing this, shout out or put in something in the chat. Or if you're not able to type anything in, let us know. Great, it's working. So I'll start talking through, summarising some of those problems. We might get a few more coming through, which will be great. Carry on if you've got other ideas. But lots of people picking up there on the type 2 respiratory failure. Quite common as somebody with respiratory muscle weakness is starting to decompensate. They've got a low GCS. Is that related to the type 2 respiratory failure? The chest X-ray is suggestive of collapse, maybe some secretions as well. We're talking about hypoxia on there. I'll move back to the other presentation just to summarise those. So yeah, as we said, reduced GCS, type 2 respiratory failure, weak cough. So we've not actually talked about assessing cough. It's going to be unlikely that they can comply with doing a cough peak flow, but we would estimate, I mean, I would put money on it being below 160. So we can sort of surmise that they're likely to have a weak cough. There's potential for increased secretion load. So our assessment's not sort of screaming out, rattling away that they've got loads of secretions that they can't clear, but they're sounding quiet and their X-rays looking like something could be going on. If they've got collapse, why is that? It's right-sided. Well, there's potential for swallowing problems. Have they aspirated? Is there stuff there that we're not really hearing at the moment, that they've got such low lung volumes that stuff's not rattling about and we're not really aware of it? So they've certainly got potential for increased secretion load. And in our sort of research around this, Nat did prepare you for a fun fact on sputum and saliva. Hope you're all ready. So approximately 20 to 30 mils of sputum is produced daily. So if this person isn't coughing and isn't clearing it, you do wonder where it's gone and how that's sort of then going to build up and what do we need to do sort of longer term. And in terms of saliva production, it's 1 to 1.5 litres a day. So if this person isn't managing their saliva, they're not swallowing it effectively, then potentially they're aspirating that also. So there's some reasons why they may have secretions. We don't necessarily have clear evidence on our assessment, but we've got some things that point towards a suggestion there. Their work of breathing, they've got a bit of a higher respiratory rate. It's not too bad, but we know they've got low lung volumes. They've potentially got secretion, so we want to try and offload that. And swallowing problems, we've mentioned, can be common in neuromuscular patients. So we know this person's on a modified diet. They've got a peg feed. They could have aspirated. The chest X-ray findings are sort of fitting with that as well. So in terms of the management, for the type 2 respiratory failure, we know that an NIV would be indicated. There's obviously lots of things that we could explore in terms of what they normally have. Do they have it at home? Have they been assessed for it before? What's the ceiling of care? All sorts of things like that. But in this acute instance, we know that it's indicated, and we're going to include that as part of our management. We can look at positioning to try and optimise some of that recruitment from the NIV, and also thinking about our secretion clearance. We've said that this person's going to have a poor cough, so cough assist is going to be indicated. We're going to put this person in the red zone from that previous diagram. We potentially then need an airway and some suction to effectively clear what we might move with the cough assist. Longer terms, of course, considering saliva management, and as we stabilise this person, we'll be thinking about the longer term management. So I've just got another slide here with a diagram from the experts sort of meeting, which gives a sort of suggested approach for managing secretions. So what we can first think about is, does this person have a compromised airway that sort of needs urgently assessing and managing? In this case, we can say that their airway is patent, the breathing. We can go on to assess the breathing. We've identified that their SATs are low, and that's likely due to hypoventilation from their ABG showing that. They've also got the hypoxemic as well. So there's a role for mechanical ventilation and oxygen there. And in some cases, that might take priority, and actually us being able to do anything else might be restricted at that point in time because they need to be stabilised. So if this person started on NIV and ED and beginning to stabilise, then that will be really helpful. We might need to allow some time for stabilisation. We might need to talk to the MDT and determine what is the sort of biggest problem here, whether actually clearing some secretions is going to optimise ventilation as well. So looking at this stage 4, thinking about airway clearance techniques, this paper refers to proximal airway clearance techniques as cough and with cough augmentation techniques. So things like the Clearway MIE would come in there. In terms of their ineffective cough, that's going and being in that sort of red zone that we've talked about, then it's going to be really important. We may also need some peripheral airway clearance, so that's where our positioning may come in, and perhaps some manual techniques alongside using the cough assist. So just thought this was quite a useful little flowchart to include. In terms of starting treatment with the Clearway, some suggested settings coming from the research. It's worth bearing in mind most of the research is around long-term use, and setup is often in a more controlled environment where the patient is much more stable, and they do recommend that you start on low pressures like 50, +15 and -15 on a self-ventilating patient, and titrate that quickly so that you get to something effective. We often start higher, and I think in an acute environment, perhaps starting at 20, and we move up quickly. We don't want to waste too much time, but we do need to bear in mind that if this is then going to become an established treatment for that patient, we don't want to put them off by starting with really high pressures and a sort of intolerable treatment that sort of gives them nightmares, and every time somebody then talks about using that long term, they're thinking, oh no, I hated that time when that on-call physio whacked loads of pressures into my chest. Yeah, starting low. The other thing in terms of starting pressures from the research is around if they're on NIV, starting at +5 from their IPAP, so that you're actually starting on an effective positive pressure. There's no point starting on 15 if they're already on 15 as an IPAP. And then aiming to have a more negative exsufflation pressure. So it should be at least 5 centimetres of water more negative than insufflation pressure. And as an example, so if you've got a setting of +20 and then -25, I cannot get my head around negative numbers, so I had to put that example in. In terms of timings, these are the suggested timings there. Having read a lot more and looked at some of these webinars that have come out quite recently, it's worth bearing in mind about the timings of the insufflation, and the insufflation time is needed to achieve an adequate volume. So it can be, you might be able to achieve lower pressures over a longer inspiratory time, but the overall aim of that is achieving that adequate volume in order to then have the negative pressure for your exsufflation. But it's not about having that going in quickly. Lots of the research that we've looked at as well talks about using the trigger setting, and this is something that we don't particularly do, and is making me think, are there times when we ought to be doing this? It does recommend that you don't use the trigger if someone's mucus plugging, so perhaps in this acute scenario we may not want to, but it's worth bearing in mind in terms of patient comfort. And with our MND patients, particularly where there's bulbar involvement, there's lots around how fast flows and high pressures can cause laryngeal closure. So using the trigger gets an active inspiration, which can open the larynx. There's a direct relationship between the muscle, which the posterior cricoarytenoid or PCA muscle, direct relationship between that muscle and the diaphragm, which opens the larynx, and then you get less of that closure. So that's again something for us to bear in mind, and perhaps if any teams are interested in exploring this a bit further, we can have a chat about sort of what we found and share some of the research. That sort of moves on to this next slide around fine-tuning the settings. So this is from Tina Anderson, who presented one of the webinars that we've had a look at, and this sort of fine-tuning summarises what you can do in terms of managing sort of laryngeal closure with some of these patients. That if you get the patient triggering, reducing the inspiratory flow, that's something that on the Clearway 2 you can do. On the Clearway 1, which we have, if you increase the inspiratory time and you reduce the pressure, then effectively your flow can be reduced. Things to watch out for is you're looking at watching your patient as you use the MIE, looking at the chest and abdomen rise and fall. Are they synchronizing with it? But watching out for if they're retching, and if they're retching during cycles, rapid cycles can make that much worse. You might need to just do one cycle at a time, and lengthen your insufflation time and your pause time. So some quite new information that we're just sort of exploring a little bit more, that's perhaps worthwhile looking at in the future. So I think that moves us on to case study 2. So I'm going to hand you over to Nat to
come back. Yeah, so we'll sort of, this is like I say, this is going to be the last case study to finish off the session really, and then we can just going to look at the key messages. So Mr. F, 66 years old, he's normally fit and well. He's got a bit of past medical history. He's just got gout, hypertension and type 2 diabetic. Admitted to hospital with proximal weakness of his upper and his lower limbs, which has been worsening over the last 48 hours at home. He's also had some vomiting and subsequently he's tested positive on his PCR for COVID-19, unfortunately for Mr. F. He has been admitted under neurology with an unknown pathology. He's been for a couple of investigations. He's had a CT head and an MRI spine that have been NAD, and we're currently having a working diagnosis of GBS, and they've commenced him on the IVIG therapy with that in mind. Whilst this chap is on the ward, managed to do some FVCs with him with an average of 1.1 litre, so done three measurements and found the average. So if we're thinking back to that diagram, or the nice the red zone, green zone from what Lorna showed you, if we're thinking about the FVC measurement on that, under a litre, we are very much looking at patients that are needing treatment with Clearway or certainly with cough augmentation. So he's very much approaching not being able to manage and not being able to have an effective cough. However, he rapidly deteriorates on the ward in terms of his respiratory function. He's got a worsening nose, he's got an increasing respiratory rate, shallow breathing pattern and a very whispery, quiet voice, and is quickly transferred to ICU, intubated and ventilated. In the next 24 hours, a tracheostomy is performed to help facilitate his weaning and rehab, as with a GBS patient, we know that often when they drop off the perch, and certainly once the respiratory system is involved, actually these patients are very sort of very sick and actually need a period of ventilation to then facilitate them weaning. I think we were talking about GBS earlier and being sort of the opposite way round to like your MS or your MND. Actually, your GBS is often start off at sort of the worst end in terms of their symptoms and their presentation, and then in theory can completely resolve over a period of months and months, whereas obviously your MS and your MND often start off sort of quite well, reasonably well, and then obviously end up with worsening presentation. So actually they're almost a bit of a flip of each other, that's what we were talking about, wasn't it? So yeah, very quickly tracheed, sort of electively tracheed, obviously not really given a chance to sort of sedation hold and all that sort of stuff, because obviously we know with GBS actually there is going to need to be a period of treatment and time. So Mr. F is now on pressure support CPAP. He's spontaneously breathing on 50%, and he's getting a PEEP of 10 and a pressure support of 10. But his tidal volumes are pretty rubbish. He's only getting 6.5 mils per kilo, so 320 mils, which is not very good for this chap. We've listened to his chest, and he's got air entry throughout, but he's got significantly reduced breath sounds to both of his lower zones. He's not got a cough on suction, despite him being off sedation. He's eye opening spontaneously. He's trying to mouth some words, but fairly incomprehensible. It's difficult for us to work out what he's trying to say. And then he's sort of centrally obeying commands. So he's able to blink to command and sort of show us that he's starting to stick out his tongue, but he's unable to squeeze hands or wiggle toes. Chest x-ray that he's had done today is hazy bases, loss of both hemidiaphragms bilaterally, and significantly reduced tidal volumes. So this guy's been with us now for a couple of days or a week, and we've sort of just been really struggling to wean him, trying to reduce his PEEP, trying to reduce his pressure support, but sort of abandoned due to him having such poor tidal volumes. So now we really need to think about what we can do to try and optimise his chest. So for ease, I will just sort of talk through this rather than go back to the Mentimeter, but by all means pop stuff in the chat if you're happy to. So obviously, probably quite obvious answer, we've harped on about it for 40 minutes, is probably this chap's going to need to use the Clearway. Again, probably where he's looking at, without even doing an FVC or a peak cough flow, again, we're probably aware that this chap's going to be in the red zone. Obviously, he had an FVC prior to being admitted to ICU. He's significantly deteriorated since then. So we're imagining him he's in the red zone. he's struggling to wean, we can't get his pressure support down, he's got significantly reduced tidal volume, so we're going to Clearway him to try to support him to have an effective cough and to clear secretions, to help his tidal volume. So we're going to try and recruit some volume and to help with expansion. Before we do that, we probably just do need to consider a couple of things before we initiate the treatment. Obviously, this is a chap that's ventilated, so it's slightly more complex than initiating Clearway with a self-ventilating patient on the ward. So things we probably need to think about are, what support is he on? So we already know he's on a PEEP of 10 and a pressure support of 10. There is a little bit of discussion probably around the PEEP that he's on. Some people might be potentially slightly adverse to taking a patient off a PEEP of 10, as there is the potential for possible de-recruitment. However, probably at this stage, there's that sort of seesaw balance, isn't there, of actually we're struggling to wean him off his support because actually we've probably not optimised his chest, and actually can we not wean him off his pressure support, and has he got fairly rubbish tidal volumes because he's actually got a lot of secretion sat down there. Same rules apply probably, actually, even though there's not overwhelming crackles and sort of, you know, harsh sounding chest when we've listened, actually has he just got lots of secretions sat in his bases that we're not really clearing because we're not getting those bigger tidal volumes, and we're just going up and up in our pressure support. So there is that fine balance, and I do think that potentially, you know, we probably should be considering doing the Clearway with this patient in order to facilitate his wean. And actually, if we are worried about de-recruiting, we potentially can go on to a higher PEEP after the treatment to sort of do a bit of a rescue therapy to re-recruit him for 5 minutes afterwards. We are going to just think about now, if we were to start the Clearway, what sort of pressures would we start with? So if we switch to the Mentimeter again.
There's just one thing before we do, and I've seen that Jade's just put a question in the chat about having COVID and whether the shearing forces of the cough would be too much. I suppose
this particular patient, what I will say is that he's not really presenting like a COVID chest, in terms of he's not got significant lung disease with that, and he, you know, actually the COVID was almost an incidental finding for this chap, in terms of I think that's probably what's triggered the autoimmune response.
We would assess how they're weaning on the ventilation, how they're ventilating. So we know that with our COVID patients, when COVID's their primary problem, some of the issues around ventilating them are quite evident on the ventilator, that the peak pressures that you need perhaps, and the difficulty in ventilating them. And actually, if this person's weaning and to some extent and is behaving more of the Guillain-Barré side of things than COVID, then it would be okay. But yeah, perhaps if this was if COVID was the primary problem, we might consider things a bit more carefully around pressures and things. But I think some places have been using the cough assist quite effectively with COVID patients, so it's definitely worth bearing in mind, but it doesn't necessarily rule it out. I will just I'm just going to move share the Mentimeter. So you should hopefully be able to refresh your screen so that you get this slide. It's a quiz, but it's not scored, and if you've got just an emoji as your sort of team name or whatever, it doesn't matter. It's anonymous. We've done it as a quiz form because we are tied into how many free questions we use on our Mentimeter, and that is the only reason. So I'll just give a few more people a chance to join, and then I'll reveal the question. I quite like the emojis as the
probably a clue is that probably Lorna did touch on this earlier, so if you can remember Lorna's so what we said.
This should now just
so what pressures would we start with? So just to remind you, this is a chap that's on pressure support CPAP. He's on a PEEP of 10 and a pressure support of 10. Potentially, what would you go for? Give it a bash.
I think the answers might all reveal after the 45-second
Yeah,
countdown.
that's
I'm not really
alright.
sure.
I know I just didn't.
Music, I didn't go for it.
Lovely. So yeah, I think most people did put plus 25 insufflation and minus 35 of exsufflation. Obviously this is just a starting pressure, and this is then what you'd use to then titrate up to what you think is required for an effective Clearway treatment. So yeah, we've gone with 25 to 30 minus 30 primarily because obviously he's already on 10 and 10, so our inspiratory pressure or our peak pressure is already 20, isn't it? So we want to go higher than that, so we've gone 25, so 5 above the top pressure to begin with, and then obviously, as Lorna said earlier, there is some research to suggest that the exsufflation should be 5 more than your insufflation pressure. So yeah, minus 30.
Yeah,
yeah, you know what we mean.
Say the numbers, it makes sense.
Yeah, so yeah, 25, 30, but it's not to say that that is going to be effective, and actually then what you need to do is evaluate your treatment in terms of, are you clearing secretions, what does it sound like, it's not going to just be that's it and you leave it there. That's just going to be the starting pressures. And again, thinking about evaluating it in terms of how many times a day you're going to treat this patient, and again, it's going to be different for every patient, but probably use the Clearway as a bit of an assessment. I think normally with a self-ventilating patient, we'd say, can you do us a big cough? And they do us a cough, and then we'd use that as part of our assessment. Whether with these patients, when they're not coughing on suction, it's really hard to evaluate actually how what is going on. So I would say that yes, the Clearway is an intervention, but often we can use it as part of our assessment. So maybe do a treatment in the morning, evaluate what you're getting up from secretion point of view, the volume, the viscosity, how do they tolerate it, how are they at half an hour after, does it improve their gas exchange, does it improve the tidal volumes, and then possibly, if you're not sure, maybe do another treatment in the afternoon, even if you're not sure whether it is required to be done or not. And actually, if you then don't really clear anything in the afternoon, and it's not being as effective, then probably you can say at this moment in time they only need one treatment. Whereas actually, if you go back in the afternoon, you're still clearing stuff and actually you're improving them again, probably do 2 treatments. And again, like we said, often the secretions almost can be a sort of like a silent factor really, and often you don't really know the secretions are there until you Clearway them and sort of start to get that turbulent airflow around them. So I do think often it is good to do it, even if it's just to assess. So thank God for Mr. F, he's getting better. He's surviving COVID and GBS. He's now successfully weaned to a PEEP of 5 and a pressure support of 0. We've been Clearwaying him BD. He's also just had some management for his oral secretions, so he was on a hyacinth patch, but we've managed to get some Botox to his salivary glands. What we want to do now really is, how do we de-escalate this man's care in terms of how do we wean him and think about getting him better? So what could we do to decide if Mr. F is ready to wean down to once-a-day Clearway? We're just not doing a Mentimeter for this, are we? I'm just talking about it, I think. Yeah.
Can't really remember.
No, so think again, pop stuff in the chat if you want to, but I'll just whiz through.
Yeah.
So what we want to do, a bit like how we were sort of titrating up the Clearway, is now think about what is the volume of secretions like for Mr. F. What now is his ability to cough like? We know he's had his Botox into his salivary glands. Possibly his oral secretions are better managed. Is he managing with his cough down and a PMV on? Actually, is he managing to cough a little bit better himself now? Can he clear into his mouth? The other thing that we can do to objectively identify whether he's getting better is repeat his FVCs. So now he's coming off the vent regularly to do Clearway. Probably what we can do is use the FVC machine on the trachea and do a series of FVCs. So we've got some here, and actually we can tell that they're a little bit better, aren't they? So his average now is 1.43 litres. So based on this and the fact that he's sort of, we can hear a bit of a better cough. He's now off his pressure support. He's got decent tidal volumes. The secretion load generally is decreasing, but there is still some stuff there. We're gonna risk it, and we're gonna drop down to once a day Clearway based on all that information. 1 week later, he's even better, and he's on high flow trachea mask, and he's managing 1 hour periods with his cuff down and his valving. We're now thinking about decannulation, so thinking about how do we now prepare him for decannulation, or what are the sorts of things that we want to be looking at or thinking about. So last quick Mentimeter for the last minute, and I will wrap this up.
No, you're lying. There's another Mentimeter.
Oh, there's another Mentimeter.
There's one for key messages.
There's 2, yeah.
So, but we're nearly finished.
We're nearly finished, I promise.
Right. So, hang on. Right, resume my share.
So yeah, last one. What can we do to prepare him for decannulation?
So hopefully this just lets you write something in. So just write any ideas of what you may do with this man.
Mm-hmm.
If you're not seeing this slide on your phone, you might just need to refresh.
I'll put in the chat.
Yeah,
don't worry. I'm gonna run through.
We're gonna talk through some stuff.
Run through the list of stuff that we've got, but and then literally last minute.
If you've already answered this and you're just waiting for the countdown, just have a think about, I know we've whizzed through things, but if you've got any sort of take home messages, if there's something that you've thought, oh, I'm going to go away and read about that, any of your sort of take home messages, that's going to go in the next thing. We'd like people to just share that, and we'll share our take home messages from just having done a bit more research about this.
And again, just thinking about the end of the session, before people do run away off Zoom, if anybody has got any other topics that they would like us to cover, it can be anything really. So obviously respiratory sort of focus, you can pop it in the chat. Obviously, we're happy to do anything really. We just want to know what you guys want. So if anybody does have anything that they want us to look into from a teaching and training perspective, please just pop it in the chat.
Yeah. And if you haven't put all your names in the chat for our register, please do that. This comes up as things come up as wrong answers. They're not incorrect necessarily. It's just that we weren't trying to do this as a quiz, but this was the only format we could sort of make this slide.
First one that's come up, occlude trachea for periods of time, with cuff down, see if he manages. So yeah, absolutely. Cuff down, tolerating occlusion, so we're looking at airway patency, aren't we? Other things are, obviously we know that Mr. F's being clearwayed via his trachea, and actually probably is going to need a period of time being clearwayed facially once his trachea is out. So potentially we could mimic that by capping him off and doing the Clearway facially and getting him to tolerate it. He's been using it for a long time through his trachea, and actually it's quite a different sensation using it facially. So potentially we might need to do that, and we also might actually need to drop the pressures a bit as well to begin with doing it facially. And then there is a bit of a decannulation checklist as well, which obviously isn't just for neuromuscular patients or sort of the Guillain-Barré's patients, just as a general decannulation checklist in general. So appropriate level of consciousness, ensuring that they're awake enough. Have they got upper airway patency? So yeah, to do with tolerating the cuff down, the PMV, or even occlusion. Minimal respiratory support. Have they got head control? Effective secretion clearance, so thinking again back to, can we convert that Clearway to facial Clearway? Salivary management, we already know he's getting Botox. Cuff deflation, we've talked about. No pending medical procedures and medically stable. So probably all those things are going to be pretty good for him. So yeah, last thing, if you can just write on the Mentimeter again, just any take-home messages really, and then just to see what you guys have got out of this really, and hopefully it aligns with the things that we were intending to, if that would be good, and then we will let you go.
Yeah. Thank you all for joining.
It will be on, we've recorded this teaching, which we will upload to our YouTube channel. So if there's anybody on your teams or any of your peers that have missed it, or if you want to tell them that it was useful, it will be on the YouTube. So yeah, let people know. We'll pop it out in an email and on the Facebook chat as well, just to let people know, because I know everybody can't come. But yeah, just to let people know.
The other thing which we could have put on YouTube is I made a playlist of some useful videos from other people, and I've saved the 2 webinars that we've used to inform part of this presentation. So if you want to go away and look at some of this stuff in a bit more detail, if you go to our YouTube channel and you click on our playlists, you'll find some of those in there. Now it doesn't look like anybody's actually on the Mentimeter at the moment.
That's fine.
So that's fine. I mean, I suppose just to finish off, what I'll say is that from the research, in terms of progressive neuromuscular diseases, MIE is crucial in the respiratory management. But I think the key thing for my sort of take-home message from doing this research is around altering the settings and the timings to individualise treatments, and how important that is. And that's something that I'd like to take forward in my practice. That you could add MIE to your assessment, as Nat said, and perhaps that we could start MIE earlier than we might sometimes think with some ventilated patients and things like that. Don't know if there's anything you want to add, Nat, in terms of your take-home messages.
No, I think it certainly uncovered a lot of things that probably we can look into, and hopefully we might be able to come back at some point with a little bit more up-to-date information. Obviously a lot of this is focused around the longer term or the chronic the longer term management of these patients, but actually there is probably some work to be done in looking at the acute management of patients in terms of the settings and how to optimize them. So yeah, I think it's just given us a lot of food for thought really. I would really recommend the webinars. A lot of the information on the slides that Lorna talked about with secretion clearance is from the webinars, and obviously,
I mean, essentially,
no offense to us, but she's brilliant in how she explains it. So I would definitely recommend.
If Michelle Chapman and Tina Anderson had been available this afternoon, they'd have been doing this instead of us. So we're very grateful to those webinars. But thank you. I'll stop that.
Thank you very much, everybody.
End recording.